Good afternoon, everyone. Thank you so much for coming to this session. It's a little heavy for an after-lunch topic, but it is one that is really critical to healthcare. So I'll just introduce myself really briefly. My name is Jessica Peck. I'm actually a pediatric nurse practitioner and a professor at Baylor University, and here with Jordan Greenbaum, who is the medical director for the International Center for Missing and Exploited Children and works at Children's Healthcare of Atlanta. So we have worked together on the core competencies, which we'll go through with you. It's almost a 4-year project with the United States Department of Health and Human Services to really help change the paradigm of human trafficking from one of criminal justice to one of healthcare. And we are making remarkably slow progress on that, just to be honest. And so we need all of you. We need you as leaders in emergency medicine to help join that effort, to help reframe that. We don't have any curricular standards, so you probably aren't getting any information in your classes. There's nothing tied to JACO. There's nothing tied to certification. It really is just kind of a word on the street movement right here. But we do have a very important resource and tool to share with you today. We're going to start off with Jordan giving you kind of an overview of trafficking, and then I'm going to move into an overview of the competencies. But we'd like to know and just kind of get to know our audience a little bit as we start, because there's usually a very wide variation in knowledge and comfort level with trafficking, and all are welcome here at this conversation table. Because if you're anything like me, about almost 6 years ago now, I had a community advocate come and talk to me and say, can you help me to develop a training for healthcare professionals on human trafficking? And my exact response was, oh, absolutely not. I don't know anything about trafficking. That's not how this works. But they had been encountering persons who were abused and exploited through trafficking who had all encountered healthcare professionals without being asked or identified at risk at all. And so after trying to find them someone else to do it and being unsuccessful in that myself, I ended up looking into the literature and thinking, okay, I don't know really anything about trafficking, but I do know about educating healthcare professionals. And as I started to look at that, I really saw that I was asking her the question, okay, how can I help you? But the right question was, how can I not help you? Now knowing what I know and knowing these patients are interfacing with my clinical practice, how can we not help? So we wanted just to start off and kind of gauge the room and see how many of you, is there anybody in here who would say, yes, I'm an expert in trafficking. I work with this, I know this, I feel pretty confident. Okay, you're the only one right here on the front row. Okay, all right. How many of you would say, I feel like I've had adequate training on human trafficking for healthcare professionals? Okay, we have mostly more of these. Okay, and one kind of sort of okay, how many of you are here because you're curious and you just think, okay, I think this is a topic relevant to my practice and I'd like to know more? Okay, great. That helps us to know. So one thing I will give you a caveat, human trafficking is a very difficult subject to talk about, and just having 50 minutes, we're not going to do too deep of a dive here because we want to be mindful of vicarious trauma. It's difficult to walk in, you don't know us, we don't know you, and just say, okay, let's dive right into deep issues of sexual violence and horrible things, honestly, that we've seen. But our goal today is to hopefully lift your eyes to say this is a health threat that will present and you will be on the front lines in the emergency room. People who are trafficked can present anywhere, but the primary place of presentation is in the emergency room. And Jordan and I were talking earlier, and I told her it's kind of like an active shooter situation. No one ever wants to have that. But okay, I'm sorry. I know, Jake. It's so nice to see you. So we want you to be prepared and know what you're going to do before that situation should happen. If you're trying to do active decision making in the middle of the situation, then you're not safe, and your patients are not safe, and this is not a safe situation. And so we will give you some resources that you can go back and look and learn more about the details and the clinical response. But hopefully today what we'll do is cast a vision to say this is a clinical problem and that you do need to have a plan for response in your clinical arena. So with that, I'll give it over to Jordan.
Thank you. So I'm going to give just a really quick overview of human trafficking to try to put it into context. When we talk about the core competencies, it'll mean something. So I'm hoping that at the end, session, you'll be familiar with the types of human trafficking and their risk factors and health impact. We're going to go over that relatively quickly to lay the groundwork. And then Jessica will describe the core competencies on human trafficking, who they're for, what they aim to do, and hopefully you can identify some strategies that you can take back to your own organization. So basically, just to get us all on the same platform, the federal definition of trafficking in persons, according to the US federal definition, requires an action, a means, and a purpose. So in order to say that person has been trafficked, you need to be able to say that that person has experienced one of these actions, doesn't have to be more than one, with the person using force, fraud, or coercion. And the fraud and coercion can be fairly subtle. It can be like, for example, taking your immigration papers, so you don't have any identification papers and you can't leave, something like that, for the purpose of exploitation. And for all intents and purposes, in the United States, exploitation is either commercial sexual exploitation or forced labor. Those of you who are working with kids, anyone under 18 is considered a child. And when we're talking about sex trafficking of a minor, you do not have to show force, fraud, or coercion. It's always there, but we don't have to demonstrate it. So that makes a big difference. The caveat here is that that only applies to minors for sex trafficking. If you have minors for labor trafficking, you do have to show force, fraud, or coercion. Very confusing, but just keep that in mind. There's a lot of different ways people can be exploited. And so there can be forced labor in the formal sector, for example, labor trafficking in construction or gardening or landscaping or hospitality, working in hotels, working in retirement communities. All of those are very formal sectors. But it can also be in informal sectors, for example, babysitting or domestic servitude, for example. Lots of things that are not typically thought of as formal occupational sectors. And then finally, it can also involve forced criminality, forcing somebody to sell drugs. Lots of homeless youth and young adults, not only do they get sexually exploited, but they also get labor exploited. They're forced to petty theft or selling drugs. That is a form of labor trafficking. And then there are various forms of commercial sexual exploitation. As you can see here, I'm not going to go into a lot of depth, but it's a variety of different acts can come under this definition. Just a couple of things to know, and you probably are aware of this. Human trafficking occurs across the board. There is no group anywhere in the world that's immune to this. So we see it everywhere in all different social groups. Don't forget about boys and men. We tend to focus exclusively on girls and women. Very much the public perception, especially with sex trafficking. But don't forget, boys and men can be sexually exploited as well, and they certainly can be labor exploited. When we talk about risk for trafficking, I think it's helpful to look at it using the socioecological model because there are so many risk factors. And it's important to remember that if you have a patient who may have experienced trafficking, they typically have one or more of these vulnerability factors, but they might not. They certainly might not be obvious. So we have to keep that in mind as well. But if you look at the socioecological model, you can see vulnerabilities and risk factors that involve the child or the adult themselves, the individual themselves. So somebody, for example, who is homeless or who is a recent immigrant to the United States, doesn't speak the language, doesn't have it is culturally, it's a new culture. Those are individual characteristics that make that person more vulnerable to exploitation by others. And then there are several risk factors that are interrelational. Typically, we look at the family and peer groups, school groups, work groups. And so having some of these risk factors within the family or the peer group also sets up people for vulnerability to manipulation, exploitation, trafficking. And then finally, at the community level, everyone in the community experiences this increased risk, for example, where there is a general tolerance of commercial sexual exploitation. For example, I come from Atlanta, which is the hub for adult sex industry, strip clubs and stuff. So there are millions of those. And so people living in the community in those neighborhoods, that's kind of there as part of it. And so that elevates the risk for the whole community. And then I think what's really interesting and what is getting more and more attention in the research is looking at risk factors at the societal level, looking at cultural bias, cultural beliefs, cultural practices that render large groups of people marginalized. So we think about homophobia, or or systemic racism, xenophobia. Many people are marginalized because of cultural beliefs and practices, which render entire groups very vulnerable because they don't have the same opportunities. So that is a really big area of vulnerability that we see, that I think is really important to keep in mind. Why should you and I care about this? Because of the physical and mental health impact. It truly is a health issue. And if we look at labor or sex trafficking, and some people experience both types of exploitation, there's a major potential physical health impact. Violence, of course, is very common, which may occur at the hands of, say, the work manager on the labor site, for example, a third-party trafficker, sex trafficker, a buyer, for example. So violence, injury, work-related injuries, because safety equipment is not used, so a lot of work-related injuries. So violence and injury is common. Unwanted pregnancies and complications associated with that are very common among females who are sexually exploited. Sexually transmitted infections. I worked at a children's hospital, and we did a study there. About 47% of our identified adolescent patients who experienced sex trafficking had an active STI, and about a third of them had a prior history of one. So it's just, rampant. And very high levels of drug use, substance misuse, which may be done for any number of reasons. Self-medication is a big one, but it can also be forced on them or sort of pushed on people as well. Over and above the physical impacts, though, I think are tremendous psychological impacts. And these are the more subtle ones. These are the things that are much harder to treat. But we still see them in the emergency department. And for many of our the kids that we've seen actually present to the ED for behavioral health issues. PTSD-like symptoms, very common, high levels of depression and suicidality. Another study of adolescents, 50% of those kids reported a prior suicide attempt within the last year. So very high levels of depression, anxiety, lots of behavioral issues. So they might come in for antisocial behavior, acting out, sort of being really difficult to handle. Somebody might bring them into the emergency department. So all of these things are reasons for potentially seeking health care or mental health care for people who have been experienced exploitation. So what's the healthcare system response? Well, it's the same as with anything else. We're supposed to recognize whatever's going on with our patients, be it a medical or a mental health condition or some sort of social condition with violence, provide appropriate medical care, and provide emotional support. And we know that people who have experienced trafficking have tremendous psychological needs, and they really need emotional support. Our role is to offer services, not only our own services, send them to orthopedics, but also services beyond our clinic and our emergency department. We're obligated to notify authorities when we're mandated reporters for children who are, we suspect are experiencing sexual exploitation. Adults, there's some mandatory reporter laws for adults as well. And then we're supposed to offer hope, that's the whole thing. Not just treat their STI and put them back out wherever they came from, but to offer some hope that there can be something better. So this is a healthcare system response, but you, as well as I and Jessica, all know that there are tremendous challenges to this, whether it's for any patient or for a patient who's experienced complex trauma like sexual exploitation or labor trafficking. One of the biggest risks to optimal care is that we don't recognize these patients when they come walking into our emergency departments. They don't come in with a chief complaint of labor trafficking. I'm still waiting for that, by the way, a chief complaint of sex trafficking. They don't typically identify, and we too often don't recognize them because we don't have the training to do that. We don't have consistent use of a trauma-informed or patient-centric rights-based approach, which is arguably the best way to work with people who have been deeply traumatized, including trafficked persons, and try to get them to build the trust that will allow them to tell us what's going on so we can help. We don't have a lot of effective screening strategies, especially really for either sex or labor trafficking, adults or children. We really lack good screening tools and protocols and evidence-based interventions and a lack of a holistic approach. Too often, as we do in medicine, we stay very siloed. We treat the STIs, we treat the whatever it is, the trauma, patch them up, send them on their way, but without ever thinking about whatever else they might need that lies outside the purview of the hospital grounds, for example. So knowing all this and knowing that it's so difficult for us as healthcare providers to recognize people who have experienced trauma or people who haven't yet but are high risk of trafficking and exploitation, in order for us to better treat them, we decided that we need to come up with some basic core competencies. And so this is like a 3-4 year now project to try to help change the healthcare response at a big systems level response to improve the care of people who have experienced trafficking or who are at risk for trafficking. So Jessica is going to take us through the project and how it might be useful for you and your organization.
So, let's make it real for you, because you are going to be in an emergency room setting and somebody's going to come in and need your services. And I think one of the challenges is, even though we are healthcare providers, we are not immune to bias, and we are not immune to false narratives that are presented to us constantly. So I think there is a lot of misinformation, and there's a lot of just assumptions that are made about what it might look like for someone who's experiencing trafficking to come into your emergency department. Now, I think as clinicians, we are a lot like, it's like when you go to the optometrist and they put those lenses in front of your eyes and they say, is this clear 1 or clear 2? As an emergency room clinician, you are walking into that room and immediately those lenses start dropping like crazy, right? And you're thinking, okay, is this interpersonal violence? Is this substance misuse? Is this, is this mental health issues? You're thinking all of those things. But what I've discovered is that we don't have that lens for trafficking to put that on there, because it's complex. It's not just trafficking, it's a whole bunch of things. And really, we have to remember that if a patient who's experiencing trafficking is coming to the emergency room, they likely are not coming because they're being trafficked. They're coming because they have a health need that they're trying to seek service for. So we can think a lot of times when you look on the news and you see, when you talk about trafficking, most of the time they're going to talk about sex trafficking. And we have to remember that labor trafficking is actually more prevalent than sex trafficking in the United States. But sex trafficking is a more salacious story. It's easier to cover on the news. And so when we're looking as clinicians, we're expecting a white young female to come and say, oh my gosh, save me. I've been waiting to say, save me, and passing you a secret note, to the pizza delivery guy. That is not how it happens. And most people who are in trafficking situations have been groomed into trafficking situations, or they're being abused or exploited or held by invisible tethers. Maybe that's substance abuse or misuse, because you're thinking, that they are trying to, traffickers want to maximize their profits and minimize their risk. And so maybe they might leave, but they'll have withdrawals within 3 hours. So they're going to go back to their trafficker. Maybe they don't know another life. So they could come into your ER and say, I got beat down because I tried to choose up and I really need to make it back to the track. And you're thinking, I don't even understand what that means. You have to ask them and say, I don't understand that narrative. What does that mean? Can you explain it to me? And their mindset is going to be, what do you mean you don't understand that? Isn't that the way the world works? So we have to remember that this is boys, this is girls, this is men, this is women, it's gender nonconforming persons. And traffickers are mothers, or fathers, or pastors, or teachers, or military veterans, or coaches. It's not just the thug that we're thinking about on the street, and we can be susceptible to trafficker deception as well. So that led us to really thinking, okay, it is a moral dilemma to raise your awareness of trafficking without giving you resources. We can't tell you, oh, this is so awful, and you're going to see these patients, and we don't know what you're going to do, but you should do something. So that's where the core competencies come in. And this was a collaborative project between the Office on Trafficking in Persons, which has a lot of really good resources called SOAR to Health and Wellness. So you can go on and take training specifically for physicians. There's a bunch of different kinds of clinicians that you can take training for, trauma-informed care, and those kinds of things. And we have, of course, the International Center for Missing and Exploited Children, Heal Trafficking, which Dr. Hanni Stoklosa was supposed to be with us here today as an emergency room physician, but tested positive for COVID. And then we have the National Human Trafficking Training and Technical Assistance Center, and then the National Association of Pediatric Nurse Practitioners. Our vision is to improve outcomes for individuals who have experienced trafficking and individuals who are at risk for trafficking. Now, as you're reading through, this might seem kind of wordy because we use this phrasing over and over again. We tried very hard not to say the word victim, mainly because many people who are victimized by trafficking do not see themselves as victims. And that is an emotionally charged word, and many people will not realize their victimization for a period of time. And sometimes it may be their encounter with a healthcare professional where they first realize their victimization, and that is a very heavy thing. And then they may go on and call themselves a survivor or a thriver, but we try to use person-centered language to say these are people who experience trafficking or who are at risk for trafficking. And we wanted to empower health and behavioral health systems with the competencies to support a transformation of these systems using an effective, evidence-based, these are the core principles right here, evidence-based, trauma-informed, and culturally responsive approach to human trafficking. This evidence-based is very important because we have a lot of well-intentioned but ill-informed organizations, and you may have attended a trafficking class. When I first started speaking, I had a lot of trouble in getting invitations into health systems because law enforcement had been there before me. And there was no translation, so they walk in and basically tell you all their horror stories and, hey, this is what happened, but we got justice and the bad guy's in jail. When we're sitting there kind of shocked thinking this is not how we do things at all. And so that can be very difficult. So that evidence-based and generating research is really important, as are all the other elements. We also we have important guiding principles for the competencies. We wanted to be inclusive of all types of human trafficking. In other parts of the world, you may see different kinds of trafficking, like baby trafficking or child soldiering or organ trafficking. But here in the United States, we mainly see labor and sex trafficking. And again, be trauma-informed and person-centered, survivor-informed. This is really important. So if you go back to your institutions and you want to get a work group together to say, we need to create a protocol, you need to have a survivor at the table. Because you can have the best intentions, but a survivor could come in and say, we would not relate to that at all. That would not make us feel safe at all. That is not going to prompt a disclosure. So having that survivor-informed piece is really important. Being culturally and linguistically appropriate, multidisciplinary is so important, and you'll see that represented in the competencies. And here we have a physician and a nurse. We also had mental behavioral health and social work represented in here, and being data-driven. So you'll see there's a universal competency and then 6 competencies to follow. So the universal competency, we were thinking about this like universal precautions. Everybody needs a trauma and survivor-informed, culturally responsive approach. And that's going to have collateral benefit. So if you build a wheelchair ramp for people with wheelchairs, people with strollers, or people using a cane, or people walking their pets will also use it. And so it's not going to harm any patient to use a trauma and survivor-informed or culturally responsive approach. The competencies are separated into specific categories. So we have the nature and epidemiology, which is still such a challenge. We don't have common nomenclature. We don't have common data systems. We don't have universal use of the ICD-10 codes for trafficking. Those were actually developed by your very own Dr. Jordan Greenbaum, sitting right here, and implemented in October of 2018. And those ICD-10 codes cover both confirmed and suspected trafficking for child and adult victims and labor and sex trafficking. But it can be risky to use those because they may report out to the guarantor, who is the trafficker. And if you think this can't happen in healthcare, some of the examples that have been in the news lately, there was just recently a group of nurses who settled a trafficking case because they were trafficked from the Philippines, promised a good job here when they got to the United States. Their wages were garnished, their papers were taken, they were given, really terrible living conditions, and what did they do? They showed up to work every day, and they worked with people like you and people like me and didn't say anything because they were afraid of their families being harmed, of being deported, of being arrested. And so these kinds of things can and do happen. We talk about risk for trafficking, and that's really important to know. It's not necessarily your role as a healthcare provider to identify someone as trafficked. It is your role to identify risk. If they're an adult patient, then they still have autonomy and agency, but you can identify the risk, inform them of that risk, and offer to connect them to services. Obviously, for children, we are mandated reporters. For competency 3, evaluating the needs, what are they coming in for? So this is really important in an emergency room setting. Sometimes when you see a trafficking situation, everything else gets derailed. It's like you forget, oh, they came in for a UTI. They came in for a contusion. They came in, that was what was important to them, not the trafficking situation. They did not present for care. It's just like Jordan said, that's not on their chief complaint, human trafficking. Their chief complaint is an injury, a chronic illness that has not been adequately managed. I had a 16-year-old who was being trafficked who kept presenting in DKA. She had type 1 diabetes. Well, we thought she's 16. A lot of times they rebel against their chronic illness. They don't do their insulin. And so it was terrible, actually, if you look back, because we would just, kind of shake our finger at her and say, you need to take care of yourself. You need to do your insulin checks. And her trafficker did not care at all about that. The patient-centered care is competency 4. Competency 5 is the legal and ethical standards. I will say that's the one we spent the most time on. That's the most difficult because you have cross-sections of immigration issues here. You have cross-sections of criminality. You may have people who come in and are exploited through trafficking, but are also recruiters for traffickers themselves, or maybe drug mules for traffickers, or they're transporting drugs or committing petty theft or something like that. And it varies by state whether or not they are held criminally liable for those actions. So it can be very difficult for us as healthcare professionals to try to navigate all of that in real time. And then 6 is prevention, and this is the area where we need most work. This is integrating trafficking prevention strategies into clinical practice and systems of care. This is where Jordan and I over lunch said we have just not moved the needle very much at all, because one of the biggest barriers is recognizing that there is a health threat that needs to be prevented. A lot of misconception I see in working with pediatrics is parents having the misconception that people are kidnapped into trafficking. You've probably seen something on social media that goes like this. I don't usually post on social media, but I was almost kidnapped by a trafficker in the grocery store tonight. Hug your babies, keep them safe. And of course, we all care about that. And, there are nefarious people who will troll parking lots and stores like that. But it really takes our eye off of what we need for prevention. I saw a story this morning about a girl who went with a man from a Dallas Mavericks game. She went to the bathroom and disappeared. And there's a lot of holes in that story as I'm reading it, but the message that parents get is, oh, yes, watch your kids, go with them to the bathroom everywhere, instead of, no, you should really be worrying about the 10,000 guests they have in their room every night with no supervision on social media. That's where trafficking risk is happening. So these competencies are for individuals. So you can go on these competencies as an individual clinician and say, what do I need to do to be able to say that I'm competent to care for people who have experienced trafficking? There are competencies specifically for organizations and health systems. There are recommended priorities for research, and there are recommended priorities for educators who want to integrate this information into your curriculum. What I find as an educator myself is that so many people say, I don't feel qualified to teach this because we have this thing in education where you have your expertise, right? Like maybe that is exactly, a specific hormone in a specific population of people, or whatever it is that's your niche. But this is something that is facing us. And what I discovered is knowing this much, my students knew this much. So we have competencies to help you feel competent as an educator. Our ultimate goal is to improve patient outcomes through disseminating the competencies, which we're here to do today, having healthcare systems adopt them and integrate them and transform healthcare. One thing we are seeing is that as some bigger healthcare systems are starting to adopt competencies and protocols, clinical protocols, We are seeing that traffickers will go and exploit underserved systems, so rural areas or places, health systems that they know that they don't have a robust connection with law enforcement, or they don't have, they're not going to ask questions. That's where people are going to go. So you may think, oh, I just work, by myself in a rural place, or, someplace that this is not going to happen, but it happens everywhere. There are definitely buyers in rural areas. So we just wanted to show you kind of one competency and show you what it looks like. The core competency 2 is evaluating and identifying the risk of trafficking. So we give a little description of that competency, basically what you should be able to do. And then this is how the competencies are listed out. So you can see individual. Do you know how to refer patients or clients who present with potential indicators of trafficking to appropriate personnel for assessment? Do you know what you would do? Do you know who you would refer them to? Do you have a social worker that takes care of that? Do you have an interdisciplinary team? Do you have a clinical protocol that is triggered? Do you know what you would do, or would you just try to figure it out in the moment? For those who are trained to assess trafficking only, you would educate the patient on confidentiality, privacy, and mandatory reporting requirements before conducting an assessment, and empowering their autonomy to share only what they feel safe sharing. Because one of the things that we care about with you as healthcare providers is vicarious trauma. This is not the time where they need to tell you absolutely everything that's ever happened to them when they've been trafficked. That can be re-traumatizing for them, and that can be traumatizing for you. It also intersects a potential criminal investigation. So if you're not trained to do forensic interviews, then you should act within your scope. Somehow with trafficking, when I see clinicians who start to recognize risk, you really are altruistic and you want to help, but you wouldn't treat any other condition that way. If a patient was diagnosed with a brain tumor in your emergency room, you wouldn't tell them, okay, well, you're going to meet your therapist today, and you're going to get signed up for chemo. We're going to do your port, and where you're going to meet with the surgeon. It's just the first step is accepting that diagnosis and then connecting them to a pathway of services. And trafficking needs to take the same path. For organization or institution, we're looking at creating a setting for the patient that supports confidentiality and is trauma-informed and culturally and linguistically appropriate. How are you training your personnel? Do you have system-wide policy to help? Because one thing I've seen happen with healthcare providers who are trying their best to respond to trafficking with the knowledge and resources they have is then they get in trouble because they don't do it how the institution thought they should have done it, even though there's no formal policy or protocol in place. And that's why it's important for you as an individual clinician to make sure that you have that organizational support, that you know clearly what you're supposed to do. So this is just an example, and then we have a bibliography on each competency to give you several additional resources. And we recognize not every competency is going to fit every setting, so you would really need to have a work group to see what is applicable and what could we provide here. I think that having an interprofessional collaboration is really, really effective. One thing that I've been involved in is coalition building in communities, so having healthcare represented, but also law enforcement. Who are the NGOs who are in your community who are working on this? Who's reputable? Who are your local elected law enforcement people, or your local elected officials, or your federal or state officials? What does your police look like? Do they have a trafficking resource officer? Has the law enforcement been educated on trafficking, or do they have no education? And coming together and having a community-based response really speaks to what Jordan showed you earlier with the social ecological model. So, Jordan, do you want to say something about this?
Sure.
I'll give this to you now.
So I think if you look at these core competencies for the organization, they really focus on all these core competencies. They really focus on you need to train your staff, and you need to have policies and procedures in place, a protocol. And so to really address that, there are some resources here where you can get good training. An online book, Caring for Trafficked Persons, it's old, it's 2009, but God, it's good. International Organization on Migration, really good global healthcare provider related training. There's other healthcare resources there. So there's a lot of online resources that can help give you the information that you need for new and ongoing employees. And the protocol guidance, protocols are a big deal. We want to make a good one that's useful, not too detailed, not 80 pages long that no one's ever going to read, but you don't want it 1 page long where that doesn't tell you anything. So it's kind of an important step, and there are some good guidelines and resources that help you walk through this. For example, this on the top there, there's a 1 hour online self-paced module that really takes you step by step by step in creating a protocol on human trafficking for your organization, a clinic or an emergency department, saying right from the beginning, this is what you do if you go to your medical director and you give them this argument, and that because you want buy-in from the top that they're gonna really use this protocol. And then who do you want on your committee? These are the people you want on your committee. So it's not only the module, but it gives you about 45 different resources that you can plug in so that you're not starting from scratch, yet it allows you to create a protocol that fits your institution. If you use somebody else's protocol, it's not going to necessarily work. So you want to have it tailored to your own department and your own institution, yet you don't want to have to start from scratch. So this helps you do that. There are these 2 toolkits that provide additional resources. So you're not coming up with, having to come up from something from scratch. So we wanted to just talk a little bit, and I don't think we're going to be able to do short, small groups in here. It's not set up, but wanted to sort of open it up for discussion. Now that you've got a taste of what the core competencies are, and granted, you haven't looked at the whole thing, but we've kind of given you an idea of what they are. How do you think that these core competencies could work in your organization? Anyone have any ideas? Is this completely off base, or do you see it would be something that could be incorporated into your health system? Probably you're focusing on the individual level core competencies and the organizational core competencies. The research in the medical school, training, nursing school stuff is less relevant for us here.
Anybody? Or if you have any questions on anything we've presented so far.
I think one of the, when we created a protocol at the Children's Hospital I just retired from, the key there was, to realize that you got to get buy-in from everybody. And so to have put all this work, hours and hours and hours of work into a protocol that just sits on the shelf and nobody reads it, is useless. So you got to get buy-in from everybody. And that was the thing I learned right off the bat, is that I thought, okay, if I want to have a protocol for human trafficking that's applicable to the health system, with the whole hospital, then I can't just have a couple of ED physicians and me creating this. It's not going to work. So we have to get everybody, anyone who's going to touch the patient, whether they go to the ICU, where they go to the floor, what are they doing? Surgeons, consultants, everybody has to be aware of this and have a stake in it. Otherwise, it's going to be your protocol, nobody else's, and they're not going to buy into it. So that was one of the take-home messages. And we had a pretty good group. It's like 20 people. And you want legal people, you want risk people, you want all those administrator people, because they need to weigh in on it too. But in the end, it was much better, because people had to sort of say, okay, yeah, I did sign off on that. And so now I'm going to have to take it back to my own team and sell it. What do you think would be difficult to have to create, say, a protocol for your emergency department? Do you think anyone would buy into it? Please.
I kind of have a general question that kind of relates to the question you just asked. My question is, how do you go about approaching someone who you suspect is trafficked in like an appropriate way? Because I think some hesitancy, maybe staff don't feel comfortable approaching patients about this issue, or like, how do you go about kind of bridging that conversation?
So are you saying that maybe you got something from the way they presented, or from something's not right?
Yeah, something just seems off.
Yeah, so, and please jump in, Jessica. What I would suggest is, I'm supposed to stay near them.
Yeah, I know, it's so hard.
I would suggest making sure that you talk to the patient alone, so you sort of get the sense that something's not right here. So you say, it's our policy here at Podunk Hospital that we're going to talk to our patient alone, so I'll have to ask you to step out and we'll come and get you in a few minutes. And you open the door. You're not really asking, you're saying go. And they do. So you get them alone and ask them if they feel okay talking to you. And then I would start out with sort of laying a little bit of the groundwork, saying, I like to talk to my patients about a lot of different things, because the more I know about you, the more I can help you and know how I can help. So I'm going to ask you some questions, and some of them are sensitive, but they may help me understand you better. You don't have to answer these questions if you don't want to. So you're laying out the total informed consent thing. And then you say, before we start, especially if you're working with a child, I'm going to try to keep this as confidential as possible. I do my best to do that. But it's really important that you as a patient know that there are certain things that I cannot guarantee that nobody's ever going to know what we're talking about. Because some of this has to go into your medical record, and other people are going to see your medical record. And if you're a minor and I'm concerned about your safety, I'll have to let other people know. So just so you know that before we start. Do you have any questions about that? Nope, no questions. Is it okay if I ask you some questions? Go ahead. Now you can go into it, and you can ask open-ended questions. Let's say you're kind of concerned about reproductive history. 2 episodes of gonorrhea in the past. Let's your move gradually towards that. And just tell me a little bit more about, I'd like to talk about reproductive history, and you mentioned that you had one STI a year ago. Can you tell me a little bit about that? You're opening the door and then having a general conversation. The things you want to avoid is this bang, 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 bang. How many sex partners have you had? How many times have you had chlamydia? How about gonorrhea? How about herpes? Then it becomes like they're being interrogated. So you want to keep it very, very open, very calm, and just sort of open the door for them. They may not step through it, and that's fine. Your goal is not to have them disclose. Your goal is to figure out, what is making me concerned about that, and how concerned should I be? You may find, for example, your concern is, well, this 17-year-old has run away from home 4 times. That's a big risk factor. So you may say, tell me about the last time you ran away from home. That's a great open-ended question. And then they can say, well, I ran away because Mom didn't get me the prom dress I wanted. Well, what did you do? Well, I went to my aunt's house for 2 hours and I was back for dinner. That's not really running away. That's not a high-risk situation. But if they said, I ran away because I'm sick of Mom's boyfriend raping me and I stay out for 2 weeks, that tells you something. Does that help at all? I've just given you a huge...
So I'll add, from my experience, really, if you go from the framework that you are just looking to identify risk, you are not looking to say, are you trafficked or are you not? Do I need to save you or do I not? Because, that rescue mentality is very harmful, because we see a lot of kids who are quote unquote rescued. You'll see headlines that say 57 children were rescued from trafficking. You read the article, these children are all from juvenile justice, they're from foster care, and they've gone back to their trafficker because that's the only life that they know. So I'll give you an example from my clinical practice. I worked in a pediatric primary care in Houston. I had a 4-year-old who had gone to the emergency room for a UTI. The emergency room said, yeah, maybe it is, maybe it's not. Her urine looked okay. We'll put her on some antibiotics, go follow up with primary care. So she came in to me, and I looked at her, 4-year-old UTI, not uncommon, right? But just that spidey sense, like Jordan was talking about, you just know something's wrong. So I did, her urine looked fine, her exam was fine, I asked all the questions, it was fine. So the sentence that I used with her was, the aunt had brought her in, and I said, I feel like you came here for something that you're about to leave without. So the more information that you can give me, the more I can know how to help. And then that's when she told me that the father was trafficking this little girl. But the aunt was afraid to say because they were financially dependent on him. They depended on him for a place to stay and for food. And now here I am all by myself in this pediatric clinic with except for a waiting room full of patients and my staff, and I'm thinking, okay, where is this dad? Are we safe? What do I need to do? And that can make it really, really difficult. Another example I can give you is a teenage patient I had who came in actively suicidal. Those lenses started going in front of my eyes. She had substance misuse. Her parents were divorced. She was bouncing back and forth between states. She had dropped out of school. She had self-harming. Her tox screen was positive for everything you can imagine. And I realized that I labeled her as troubled. And if I had asked her, are you by chance a victim of human trafficking? Dun, dun, dun. She would have looked at me like I lost my mind. But when I started asking questions in a trauma-informed way, just like Jordan said, she told me that her dad was the greatest person in the whole world because she was the reason her parents got divorced, and she was, she dropped out of school, she used drugs, she was no good, in her words, but her dad came and bailed her out every time, and he let her stay with him even though he knew she used drugs. And all she had to do was just sleep with his friends so that they could make money for rent. So once I think you underestimate too just how normalized the life, they call it the life, is, and how much they will share with you. I'll give it back to you, Jordan. That was a great question.
Thank you so much. I think, like, if you're talking about how would these work in our organizations, I think having this information is extremely helpful. Like having all the data set up so that we can bring it to the leaders of our organization and say, like, this is what has been shown, this is what has been researched. Because sometimes it's really difficult to do all of that research on your own and figure out what's been out there, especially because there's not much data in the field. I know with medical schools, when I've tried to help like integrate curriculum into theirs, like I try to give the medical students like a whole packet, like step-by-step process. This is how you talk to your administration and things like that. And they have found that very helpful because a lot of people don't know where to start.
Yeah.
Like there's just so much information. They want to do something, but they don't know where to start. So I think this is incredibly helpful, and I think it'll centralize things so that information is coming from one source and it's not a different approach at every hospital.
Yeah.
So I think if you're looking, I guess, for feedback about what you think about that, I think that is really helpful.
Well, thank you. Thank you very much.
And it is HHS, so that helps, you know, that it is HHS. And so Jake and I have actually met before, and you walked in a little bit after I asked if there was anyone who would consider themselves an expert in trafficking. He would have raised his hand. No, you should have raised your hand. Any other questions? Yeah.
Yes, please.
These programs, I mean, if we were to go into these sites, provide specifics in terms of how to handle certain things. For instance, the scenario you gave us about, you know, talking to the patient alone. They're not all going to be that compliant.
Yep.
And will say, yeah, sure.
Yeah.
I'll just step outside and go, you know, have a
Yeah.
lunch or dinner while you talk to my daughter. So, you know, is there specific strategies that they would offer us in terms of
Yeah, I think that a lot of the trainings vary, and some of them are very they're very didactic and not all that interactive. But some of them are really sort of in the trenches with those exact type things. So they would say, "What would you do?" And then they will provide examples, like saying, "Well, you know, the easiest way is to say it's our policy, it's our procedure here at the hospital to speak to our patients so much. So I need to ask you to step out." That doesn't work. Okay, then Plan B is when you decide that the child or the adult or whoever your patient is needs to leave the room for some reason. Go get an X-ray, go down to the bathroom, so you take that person out while the other person stays there. So you have a couple things in your back pocket, and the good training ones do have those practical approaches because there are certain key areas of you know, how to talk to your patient about what's going in the medical records. They have information on that as well.
mentioning what's going into the medical record is actually key. It's something we did not factor in. So our group did a simulation of sex trafficking, identification, recognition sort of deal. And we took it actually, we just let it go. And if the paramour or the trafficker refused to leave the child alone, threatened to just leave. And so then in the debrief component of it, we were trying to see what were our options at that point. Because I don't know for sure, but my intuition is that if it came down to a threat, that the victim or the child would probably leave with them out of fear more than anything else. And so we wouldn't be getting very far. And I just didn't know, to this day, I still don't know what my point would be.
Yeah, I think those are extremely difficult. You can't lay your hands on the child. You certainly can't. You can notify security that something is really coming up, and they can sort of make their presence known. What I would often do in child abuse cases in the past, if the parent was saying, I can't believe you're accusing me, or somebody of abusing this child, I'm leaving. I'm taking my child, I'm leaving. What I would often say would be, I can't stop you from leaving. But it is important for you to know that because of my concerns, I'm still going to have to call child protective services and the police. And the police are probably going to come to your house. And do you really want that? Do you really want them to put their lights shining to your house? And most of the time people say, no, so calm down. Now that's not necessarily what you do with the trafficker, but I think that we have to prioritize the child's safety for the most part. If you get the feeling that the person is not going to the child, be wrong with you. we back off. We're not going to put the child in danger, but we do put that in line and say, okay, that may be in my direction. But that's extremely hard.
Is there a screening tool? I've seen like, a few questions, screening tools in the past. You're smiling, so I'm guessing you're getting there.
No, I was just, we were just talking about this. The screening tools that are reliable and valid were mostly authored by this person right here, Dr. Greenbaum. So that's why I'm smiling and nodding. But, screening tools can be problematic for this because it depends on the setting. So the bottom line is any screening tool that you use should be designed with scientific rigor and assessed for reliability and validity. And also the disadvantage with screening tools is they can be like IPV screening tools. Do you feel safe with your partner? Have you ever felt like, and then the partner standing right there. So yes, screening tools can be really important, and you can read about some that Dr. Greenbaum has looked at and implemented. But really it should be thought, does this match our patient population, and is it appropriate? Okay. And I think our time is up.
Yes.
Okay. All right, well, we'll be out in the hallway for a few seconds if anybody has any questions. Thank you so much for your attention. We really appreciate it.